Right over here. Oh, there it is. Can you hear me now, Harmony?
Yep, I can hear you now.
Okay, thank you. So I'm gonna ask you to go back to the beginning of the agenda. I'm sorry.
Welcome, everybody. I hope everybody had a good break.
It's just so YouTube captures it, otherwise it's
I hope everybody had a good break. Welcome back. We're adding two things to the agenda.
Hold on a second. Jeremy, it was us and we've got it resolved now. Can you hear me? Okay.
All right, Jeremy, I have to repeat everything though, so I'm gonna restart. Okay, so adding two things to the agenda, after, as part of new business, one will be a discussion of the Kava Lounge and Tea Bar, related to some action that was taken by the state on that. That's not part of the packet that you received in advance, but the letter is here. And then the second is that the nominating committee needs a little bit of time to speak with the board regarding replacing Sue Merkel's place. So with that said, we are going to go ahead and speak to the actual agenda for today. So nobody here for privilege of the floor. So if we could take a look at the minutes, first from Ravinder, second from Shauna. Any discussion on the minutes, edits needed? Okay, all in favor is written. We're unanimous. So let's go ahead and go to the financial summary from Jeremy. The financial summary is not in the written packet or the paper packet that you have, but it is in the online version. It was in the electronic version.
Okay, I can give a quick update here. The budget's going to look a little bit wonky for the rest of the year because the new salary contract has gone through. And in the past years, they would then adjust our budget up accordingly. But that's not the approach they're taking this year. They're going to take an approach of they'll adjust our budget if we go over budget in some functional units, which we may. And then we'll just have to ask for it at that point. But it is going to make our budgets look a little weird for a little bit. So we are working on it internally to give you all a better with the projected budget of what it should have been as well, so that you can actually tell how well a program did. Because without that, it's going to make every program look pretty, the information is not very good. So we're working on something internal for the beginning of the year so that you guys can actually assess how well or how poorly they did against budget. And separate from the county books. But we had anticipated that they were going to add it and they did not. So now we're just pivoting. We're going to do some different work so you guys can assess better. So when you see those percentages against budget for expense, they are all going to look much higher for the rest of the year. Everyone at this point, I believe, has gotten their back pay. That happened in October and then again in November. So that's quite a bit of money. And then everyone has been being paid at their new rate, which again, is significantly higher than what we had budgeted. So for a little bit here, your reports are going to look weird, but for the beginning of the year, it should be cleaner. We'll give you a separate report. And in the meantime, we are doing our year-end budget purchasing and all that. Most of it is due by the end of this week. So most of the rest of the purchasing will be done early in December. And I don't have any other concerns about going over budget or any other revenue concerns at this point. Any questions for me?
Just a point of clarification, when Jeremy referenced earlier about going over budget, it's going over budget in relation to the fact that we didn't get the salary increases put into our budget, but we're paying those salary increases. So it's not as if we overspent, it's just the way it looks in the books until Jeremy and his team were able to put together an internal report that accounts for that.
So it's just explaining the variance.
Correct.
And then is also what he's saying is, like, for example, if you underspend in community health, then your budget will, but you're over in public health administration, for example, they're not putting more money into the budget to cover public health administration because you're under in other areas.
So that's part of it,
Okay.
but also at the end of the year, they'll look at the totality of the budget.
Okay.
And if we have overspent our total budget, then they will give us the portion of the salary increase that needs to get us to zero.
That's right. We have step one in the process is look at all the savings we already have and apply them to overages. And then if the overages are above and beyond that and they're salary related, we can request the county adjust our budget accordingly to cover the rest because they did not put the salary in. So we will do both. We'll try to save all the money we can save and cover everything without asking, but we will ask if it goes over further than that.
Shawna?
Yeah, I guess my question is in regards to our Department of Mental Health. I know that that operates at a deficit. How is it that we're able to balance our budget whenever that's at a $250,000 in the red? Is that right?
Well, no, so the clinic, it's the mental health side of things, I think is roughly gonna be close to $1.8 million, Jeremy, in county share that's applied to that. So that's target, that's already part of our budget.
Okay,
So there's already a county commitment to fill the gap,
okay,
a very large gap.
Yeah.
In the clinic. Where you might see discrepancies is we may go over in the clinic, but be under in pros or vice versa. And so we manage and watch that year round to make sure that at the end of the year within our department, we're coming in below budget total. And then Jeremy and his team, when they prepare the next year's budget, they're looking at that and making adjustments in the next year to account for it. But all that occurs within the target that we're allocating.
okay. And I will say, as far as your department, I've never worried about your department. You guys are always right under. So
Yeah, well,
that makes me
now,
happy.
yeah. That was definitely in large part to Jeremy and his team. When I started at public mental health, there was a significant deficit every year and we've rectified that. A deficit to budget.
Yeah.
There's always a county share because, you know, the safety net clinic, but as far as finishing the year needing more money than the county thought they were gonna have to give us, we've really cleaned that.
Yeah, just to add a little context on that one, because we can have a conversation about mental health separate from this as well, but we're doing significant work. We just brought on a whole new workforce of people to bring them up to speed. And next year, our expenses are going to be very high because most of those positions are filled, but there will also be up to speed with bringing in revenue, hopefully early in the year. So they start to counteract. This year, they're all brand new. We have all that expense, but we don't necessarily have all the revenue for them. But we are able to find the savings within our department because we still have vacancies. But going forward, we've hired really well. And so it's going to be a little closer on the margins. We won't have all those vacancies to cover these things, especially if we can hire a medical director, which is our hope in the new year. So.
Other budget questions? Okay. Thank you, Jeremy. Let's go ahead and move on to Brian. Oh, I'm sorry, to Dr. Clayfax.
Oh, good afternoon and happy holidays, as people were saying. The only thing I would add is that with regard to H5N1 or avian influenza, fortunately, we're in the same position as at the last report. There are a number of opinions being put forth by experts in the area of infectious disease, arguing that nationally we should be doing much more to contain this by virtue of increased testing and surveillance. I'm given to understand that we may see a universal testing of milk products in New York State in the future. That would be a step to try to safeguard the New York State population even further. There have continued to be human cases, although by and large mild, although there was one in Canada that was alleged to be due to H5N1 that has been a sad case. But so far in New York State, no dairy herds have tested positive, no humans have been infected that we know of, and we are continuing to monitor it very carefully on the state level. So hopefully it'll stay that way. And hopefully any needed national measures to adequately monitor it and intervene will be taken. So any questions from anybody about my report?
Questions? I mean, I think I was a little curious about the section on the primary care physicians and why now? Like, what, was there something that precipitated that,
This is a continuing saga
okay,
that has been a story for quite a long time.
Right.
With predictions made in the past about impending worsening of the situation. And we are continuing to be in a deteriorating situation. You find people, for example, on Medicare who can't locate a primary care physician because of practitioners not finding current Medicare environment to be conducive to expanding their practice in that area. You find that we don't have that many available slots in our region for people to get into primary care. So it's an issue. And this background information, I thought you might be asked as a Board of Health member out on the street, you know, why is it I can't find a primary care doctor? Or why is it I can't get X, Y, Z? So having some background, I think, helps arm you a little bit with some things you can say.
any other questions or thoughts from? That's helpful, thank you.
Yeah, just a comment that peds is really struggling now too. Our downtown practices are pretty much closed, and those that have patients already are booking out into June or July for well visits. I've been seeing a lot more kids on campus. Like we're finally starting to track them, but I've already seen in our region, we've done 96 physicals on kids, which is way more than we've ever done. And it's yeah, the practices are pretty much closed. Some of them will only take people who are new to the community. Jamie Lair's practice is not even taking family members at this point, and so people are really struggling.
But why, so why have they closed? Just practitioners have left the area?
No, I don't know. I think there's a shortage of providers. The providers are full now. The peds residencies didn't fill this year, so it's just gonna get worse for pediatrics. Yeah.
I can add from a health system point of view that we are aware and we have been working on it. That this is a chronic problem, that primary care, including pediatrics, is really not valued the way it should be. And we've been saying this for many, many years. There is no incentive. Actually, there are disincentives for a medical student nowadays to go into a family medicine, internal medicine, pediatric residency. So this has been coming to a head for many, many years. The system is aware. That's one of the reasons why we invested in an internal medicine residency program, and the focus of the residency is primary care. And I would say the program has existed for 5 years. We have retained half of the class pretty much every year, but it's not enough to, one, close the gap because there are providers retiring every year. And even with those that are retiring now, there was still a larger gap there that we may recruit every single resident that we train, and it's still not going to be enough. On the pediatric front, we are recruiting too, but it's difficult. We have a good position that has been posted for months, almost a year, and we had 2 candidates, and although they are excellent, it feels like pulling teeth to convince them to come here. It's a struggle every year. And I'm talking about physicians, but it's not just physicians. We have a nurse practitioner here too. Ithaca College has a PA program that we recruit heavily from, and it's still not enough. We did the math. We need more than 20 new primary care providers, not just replacing the openings. It's that plus 20 more to fulfill the needs of this county. Okay. We keep working. I don't know what to do about this. So it's a very complex and large problem. So, and I think it's not just about the training, it's about getting people to stay here, right? Which is that, you know, we train 50 students, we graduate 50 PAs a year, but we're not, 50 PAs are not staying in the community. So I think it's a structural problem that comes down to the way healthcare is provided. I think in Dr. Clayback report, he shows what the burden of a primary care provider is. That you went to medical school, PA school to take care of patients, not to fill out forms and be dealing with the bureaucracy that has been created. That's really discouraging. And the system really incentivizes the procedures and the more complex things, forgetting that what we really need is the basic care. Everyone needs that. And a few will need the more complex procedures. So,
And also, I think with PAs, I think there's regulations that prevent them from doing things.
Well, you have to have it. I mean, you have to have a practicing physician for one.
You do, and nurse practitioners don't, and there's lobbying, but even in the schools, they are, and in OMH clinics, they can't practice to the top of their license, and there's strong pushback against some of the legislation. So I do think we need to advocate for PAs too. They can't be medical directors for schools. They can't practice above like anything in OMH clinics, right? And so some of the laws have not caught up with the need for the community. So I think we need to start looking at it too. That's my 2 cents.
other thoughts? Frank?
I just wanted to emphasize the two things that were in the written report. One, on November 12th, we opened the satellite mental health clinic here in the building. So it has been operational for a couple weeks now, soft launch. We have one full-time clinician and others that are rotating between the two buildings. We expect in early January, we'll be kind of humming along with more regular activity in the building, but so far so good. We've dealt with a couple of issues that aren't normal for this building and are working through some of the logistics around that, but so far so good. So good news there. Not so good news, and not to steal Jess's thunder, but the state launched a new system called EI Hub for early intervention services that is for both the providers, for the counties and the state. And as you can imagine, launching a statewide system didn't go as smoothly as we might have hoped. There were some flaws in the system, the system was very slow to begin with. They made some repairs. They're working on things. One of the biggest challenges is there was a lot of training offered to the providers to get prepared to work in the new system. Quite honestly, many of them did not participate. And I can understand why. They weren't paid to participate. And it was something else that they were asked to do on top of already being underpaid. And so now we're in this double whammy where the system isn't great. And we have a bunch of people that don't even know how to really do the basics of it, which has impacted some people getting paid. The state has implemented some emergency contracting mechanisms so folks could get paid around the system, but that's more work and more things for, again, people that are already underpaid for the work that they're doing. So our staff has been working very hard to understand it from our perspective, because there's a role we play that isn't working exactly how we might like it to work. So we have our own issues. We've also been advocating with the state. There's been weekly meetings with the PCG, the company that built the system, and the Bureau of Early Intervention to provide feedback. But it's bubbling up, and it's worse in other counties than I think it is here. But we do have some people that are being impacted, and staff is doing the best they can to try to support those folks. But we we can't stop everything we're doing to offer training to people because then everyone won't get anything because we've stopped. So it's kind of this, chicken and egg thing. Where does it make the most sense? I know Jess has a plan in the coming weeks to bring all of the providers together and do a training of some sort to get them caught up to where they need to be in order to work in their system and the system that we use that hopefully will make it a bit easier. So just wanted you all to be aware of that. I know some have heard from community members about it already. We're doing everything that we can to try to help support the providers through that. I don't know, Jess, if you have anything else on that front.
Yeah, I mean, I prepared a 3-page summary on this.
Okay.
But you covered most of it. I thought it would be helpful to give a quick timeline of what we did to prepare, where we are and where we're going. A lot of this you've already said, but we've worked internally for 6 months prior to the launch. We've prioritized meetings and trainings and in-person trainings that were offered to us. We provided space for providers to come here and watch trainings with us and have the dialogue after to talk about working in the sandbox system, which was just a fake system to prepare yourself for the launch of the new system. We are continuing to have our weekly meetings here. We are troubleshooting specific issues with providers daily, with phone calls, text messages, emails. We have submitted 392 claims so far after the system launch. We only had 40 claims go through. There were multiple billing errors, which I'm assuming is also occurring on the provider's end as well. The state has recently announced that they're lifting the top 4 billing error restrictions to have these claims go through. That doesn't fix the bigger picture because when they're put back into place, we'll have to figure out how to navigate the system with those errors. But for now, those errors are being lifted. We are resubmitting all of our claims. We did it this morning, so hopefully majority of them will go through after that. I just wanted to talk a little bit about the stipend for these providers. So the stipend contracts went out around the same time as launch. It was not intended to do that. It's just how the time worked. And the stipends for these providers and agencies were to offer some monetary assistance for time that they're not getting paid for, one of which was trainings. So year to date, we have paid out a significant amount of stipends to these providers. So I'm hoping that some of that will help in the time that they're not receiving payment. Like Frank mentioned, they have a stopgap payment contract offered to the providers right now. It's a temporary contract that they have with the state that will provide the providers with some payment while they're waiting for the system to get fixed and these claims to go through. They've lifted the 90-day timely filing claiming as well to help with payments. And in the future, we are going to have, once we as a county understand the workflows of the system, which has been very difficult, we will have a provider meeting where the providers and agencies can come together. We can sit down, work through some cases and kind of see whose tasks and responsibilities each of these items land with. I do want to just emphasize, I'm very proud of all the staff that work here. They have really put in a ton of time and effort. They've put aside other tasks and responsibilities and prioritized learning the system. I would say 90% of our day is spent talking about EI Hub and working through specific issues. They have shifted their work schedules and worked in the evenings because the system works a little faster in the evenings. So I just wanted to let everyone know that I really appreciate the dedication that the staff has had to learning the system. I hope that was helpful and it provides a little bit of context about EI Hub and where we are and where we're going.
So thank you for bringing this up. I wrote Frank an email or I called you. I don't even remember. It was yesterday. I was accosted in the parking lot of the Ithaca High School. And it was one of our providers who said that she hadn't been paid for 10 weeks. And I know that we currently have a really hard time recruiting providers. And I'm at 10 weeks of no salary for most of us would probably sink our families. So I'm glad to hear that you're helping and there's hopefully a path forward. Because she's been doing this work for a very long time and we need to keep her happy.
I will say that our wait lists have not increased during this time, so children are still receiving services. I do have 3 or 4 new providers that I'm in discussion with that are working on their contract with the state to become early intervention providers. So that's all great news. We haven't denied any services or frequency of services for children during this time. I know that has happened in other counties, but it has not happened in our county. So I'm very thankful that we've been moving along, at least on the children's side of that, receiving services. But to Shauna's point, when are people gonna get paid? Yeah, that is a great question. I unfortunately don't have the magic ball to answer that. Providers can, hopefully soon, because the claim rejections have been lifted. So if they had billed and have been rejected for these top 4 reasons, if they rebill now, they should go. They should be getting paid at any point in time. None of our providers in the county have taken advantage of the stopgap contracts with the state. We received information from the state that said none of our providers have taken advantage of that, which they could be getting paid through that as well. But they have received all the information on how to sign up for that.
Do you know which providers are having their claims rejected?
We do not have access to see specific provider claiming information. So I do not, unless I specifically asked each individual provider. We have about 10 independent providers and 4 agencies that work in early intervention. The communication that I've had with the agencies and the providers has not been around payment. It's been around, can you teach us how to use the system? So that no one has specifically said to me, I have not gotten paid.
Yeah, it's so much fun. It's been one thing after another with the state processes, and quite honestly, I don't think there's a recognition of how dire the situation is across the state. With the lack of providers, and in large part, it's because the metropolitan area of New York State does not have similar problems. Because you can make a living at the rate levels that you have when you can stay in one building all day and see a full slate of children, or you can be in one neighborhood and see a full slate of children because of the density that's available that isn't available to the rural parts of New York State. And so this is an ongoing problem, and I'll say it again, over and over again. The foundational issue here is rates are not high enough, particularly in upstate New York. And until that is rectified, we're just kicking the can down the road. And every time the state does something, it's complicating the situation, and in many instances, costing the loss of providers. We are fortunate. We are growing and things are changing. And I think that's in large part to the legislature's commitment to paying the stipend. Here in Tompkins County, there are counties around us that don't have anyone to provide service to. Right? There are children that are getting evaluated, saying they need services, and they're not getting them until they get to elementary school, to kindergarten. It's that bad in parts of upstate New York. So yeah, it really is fundamentally about the rates and getting that. Everything else is just, it's noise, right? And it's making it more difficult. Sorry, I'll get off my soapbox. That's the end of my.
Any other questions for Frank? Okay, community health.
Yes, I'm enjoying the feeling of being fully staffed. Last week, a nurse position was filled and our new nurse rose started November 12th. So that's the great news from us. And other than that, I don't have anything to add to my report.
Any questions for Rachel? Sam.
And just before Sam gets started, I did ask Sam to give an extended report on the process of the shot chip and kind of where it stands. So she and Ashley are gonna spend some time talking about
Great.
it. You can do it now.
Well, while Ashley's her screen, I will just add that, we are also at the full time for our community health paper team this year. It started, in October. And then I just wanted to highlight that we, worked with the videographer who made the, video about our COVID community resilience mural downtown to make a 30-second clip that is in all the, in Regal Cinema, in all the movies for the holiday season. And so it's very short, and then it is ending primarily with the message of staying up to date on all vaccines. So if you go to any of the big blockbusters, you can see the video. And lastly, just to let folks know that the county is launching a new website platform, an update on the website that should be in like mid-December. So go to any of the county department websites. Ashley Lewis, our public health fellow, is joining me today so we can give an update about our community health improvement process for the CHOT and CHIP community health assessment and the community health improvement plan. So overall, the state required community health improvement process is on a 3-year cycle. That includes public health really leading the process, social service agencies, healthcare, partner with Cuyahoga Health, our health system locally, and community members to assess unmet needs, propose strategies and interventions, and then monitor those interventions throughout the years of the. So these are the partners who are involved in our steering committee, who have been now meeting to plan and start implementing this process for like almost a year, I think. So this has been a lot more planning than we've done in the past. And many of them were involved in previous cycles too. And this round, I think I've mentioned before to the board, we have adopted this framework that was created, a national framework that was created by NACCHO, the National Association of County and City Health Officials, and it's called MAP 2.0. It's an updated version of a framework called Mobilizing Action for through Planning and Partnerships. So it's been around a long time, but they updated it probably during the years of COVID. And so this is the graphic that we borrowed from them, and phase 1 is hidden by the bar at the bottom, but that says build the community health improvement foundation. And then we'll cover the other phases too. So as part of that first phase, I think this was the last update I probably gave the board verbally, was when we did some events and posters around the community, collecting input about a community vision statement. And the 2 questions were, who is in our community? And in 5 years for our community achieved health equity, what would be different, or what would it look like? And so the results from about 15, it was a combination of a couple events that we did and having poster boards in different locations around the community. We got 282 responses for that first question of who's in our community, which covered different identities, diversity of
of people in our community, and then 170 responses about this vision. And so a lot was about healthcare, housing and food security, and a comfortable community with recreation. So this is the community vision statement that came out of compiling that input that we received. So I'll let folks read it for a moment. I think overall it aligns quite well with our mission statement for whole health too. So we created this and it's helping to guide the process.
So Sam went over the activities that we participated in for phase one, which was building the Community Health Improvement Foundation. I think it was back in June, we wrapped up phase one and I've moved forward with phase two, which is telling the community story. So that's the phase that we're still in currently, and that's what I'll be giving updates on right now. So for one of the first steps of phase two, we developed the assessment design team, which we wanted to kind of work similarly to the steering committee, which is like our more general oversight and collaborative group. But for the ADT, we wanted it to have a more specific purpose in providing oversight in the development and dissemination of the 3 assessments that are included within CHI, specifically in like their context and cultural acceptability within our community. And I was just waiting at Melissa because she's actually on it. I think she's the only one in the room who's on that group. But just kind of give an overview of who all else is involved. This is not a complete list, but we have a representative from the Rural Health Institute, I believe 2 from Cornell and PH, Cayuga Health Partners, the Community Justice Center, Tompkins County Communications, Ithaca Police Department, CCE, specifically the Family and Community Development Group, Cornell Sporting Center, and a variety of community members. And just to reiterate, it's not a complete list of all of the hats that everyone in that group wears. So that group, I believe we started back in August, and it's been going pretty well in terms of them providing oversight for the development of our assessments. And that group meets monthly. So to kind of get into the 3 assessments that I've mentioned a couple times so far, these assessments are meant to address the cross-cutting themes that we've pulled out of both from the map process and from our overarching goals for what we want the township to describe. So these overarching cross-cutting themes are strengths and capacity, systems of power, social drivers of health, and social behaviors and outcomes. So pretty much what this means is those are the main buckets of things that we want to be able to describe about our community once we've completed the assessments. So to get into the particulars of the actual 3 assessments that we're doing, there is the community partner assessment, which is focusing on resources, capacity, and programs of organizations impacting the county's health. And I'm happy to say this assessment is already checked off, it's completed, it's set aside. So then there's the community status assessment. And the focus of this is on health, behaviors, and identities of our county's population. And this is the more traditional community health survey type thing. And then lastly, there's the community context assessment, which is focusing on the influences, environment, and sentiments experienced by the county. And this is the one that kind of matches to the focus groups that have been done in previous cycles. So that's the qualitative assessment of the 3. So like I said, the community partner assessment has already been completed. For the survey portion, Oh, sorry. So the community partner assessment had two main components. One was the survey portion and one was a discussion-based portion. So within the survey portion, we got responses from 76 organizations. And it was a pretty comprehensive survey. Some of the feedback we got was that it was too comprehensive. So we'll keep that in mind moving forward. But if anyone is interested, we do have a public-facing dashboard with results from this survey that we'd be happy to share with anyone. But to give kind of an overview of some of the key pieces that we pulled out from the response, 66% of these organizations listed creating long-term permanent social change as one of their ideal outcomes from a more collaborative community health improvement process. 76% of these organizations reported having an advisory board of impacted individuals. And 79% of these organizations reported that decision-making power is held by a board of directors or trustees. So the reason that these three statistics were the ones that we pulled out is because that kind of shaped the topics that we chose to include in the qualitative piece of this assessment. So for the qualitative piece, we focused on power, transformative change, and accountability. So to back up a little bit, transformative change is kind of spoken to by that first bullet. Accountability is spoken to by the middle, and power is spoken to by the third. So for this qualitative follow-up, we had 35 participants, which were representing 22 organizations and 2 community members from the Health Planning Council Advisory Board. So the key findings from our discussion were rethinking funding models, breaking down silos, ensuring transparency and inclusion in decision-making processes, shared accountability, equitable resource distribution, and involvement of diverse community voices, particularly from marginalized populations. And clearly, a lot of these key themes that we pulled out are not things that can be addressed by the community health improvement process. But I think that part of the process is pulling out these ideals and goals and being able to show them to the people that do potentially have the ability to make these things come to fruition. So the second of the assessments, the one that we're currently working on, is the community status assessment. And like I mentioned, this is the more traditional community health survey type assessment. So what we're working on with this right now is we are looking to finalize a repository of secondary data indicators intended to describe our community's current status regarding the topics included in the prevention agenda. And that's a really unnecessarily wordy way for me to say that we're planning on relying on secondary data when possible in order to decrease the survey burden on our community members. So the cutoff that we're using for that is 2022. Data is 2022 or more recent, with the exception of school year related data, since that would be 2021, 2022. And we have had relatively easy time finding the data that we wanted for that, to pull out the indicators that link like our county's metrics to the prevention agenda. Some of the data that we would like doesn't exist, and that's kind of where the health survey steps in. So we're also working on finalizing this very brief community health survey that we're hoping to have disseminated in the new year, possibly sooner. But I think the new year is really more what we're looking at right now. And this is also focusing on the social drivers of health as outlined in the updated New York State prevention agenda, which, if anyone is curious, that will be released to the public in February. But those domains within the social determinants of health is economic stability, social and community context, neighborhood and built environment, healthcare access and quality, and education access and quality. So both the secondary data repository and the community health survey are focusing on these topics. And then lastly, the drafting and review of both of these tools is being done collaboratively with both the assessment design team and the steering committee.
The last assessment is this community context assessment, which Ashley had mentioned, really focuses on qualitative data collection. And we're hoping to do that in the spring. And we've been in conversation with a professor from the Cornell Masters in Public Health program who teaches a course about different methods in qualitative research. And so she's going to engage some students in some different topic areas. And then we've also been speaking with Civic Ensemble, who has come to some of our partner events. They are a local theater company, and they have done some really interesting work using some innovative strategies with different populations and focus on different topics in our community over the years, including individuals who were previously incarcerated, without substance use disorder. And so I think that they've been really pretty engaged and are interested in how they use some of their strategies to create conversation and to better understand some of the issues. So we are, we're excited to keep thinking about what that can look like. So I think that's about it. We wrote up a couple of questions for your input, but also just any questions you might have or questions. Are there any specific indicators you think are critical to thinking about for either our secondary data review or capturing directly from community members? A lot about interdisciplinary collaboration. What steps can we take to break down silos in our community? And then back to the community vision statement and other processes, just how other goals, how you feel they align with your experience living and working, all the above in our community.
Can you send the board that PowerPoint so that we can actually think about those questions?
Yeah.
I mean, I guess my reaction, so first of all, thank you. This looks like it was a ton of work. Thank you, Melissa, if you've been serving on one of the committees, but so one curiosity question is actually related to the hospital, because I know that they have their population health center and you have a set of strategies there and how that overlaps with this. That's one. And then I guess the second is this is not to be dismissive, like community health assessment is not a new thing, right? And it's really hard work and it's very complex. And I'm looking at the second bullet in particular, like the interdisciplinary collaboration. And of course, but it's so hard to do. And it's hard not to feel just a little bit defeatist about the ability to move things forward because there's so many players and really getting resources to work together in a way that makes sense, that isn't in a siloed manner, is just incredibly hard. So anyway, that was a little bit more of a negative statement than I wanted it to be, but I think it's just acknowledging that this is really, really hard work, right? That's going to take a lot as a community to, I think, achieve what I think is a very good vision statement. So I'd like to live in that community. So.
For the health system point of view, I don't know if you want to add more, Sam, but the CHP, the Clinic Integrated Network, is where population health resides. And our Chief Diversity Officer, Herb Alexander, is also a member of the board of CHP, employed by CHP. And I know he works closely with Sam for the alignment that you are describing, because we are taking care of the same community.
I guess, I don't know, the names keep changing, but like Population Health Center, their health equity team, essentially, I mean, has really, Activa Health has really shifted. I mean, it started in the last round that we did in the community health assessment where, they've been able to be a lot more involved and, with that focus on the metrics for health equity that the health system's looking at, I think there is a lot more alignment in moving through this process, which has been a really valuable experience, I think, for both health department and Activa Health.
Yeah, any other thoughts or comments? Okay, Jessica, did you have, okay, I'm pretty exhausted. Okay. And Liz, do you have anything that you would like to add in addition to what's in your report?
I'll just highlight that we are recruiting for an environmental health specialist to work primarily on our food service program. Open until the 16th. So, December, if anybody knows of anybody, please encourage them. We have civil service testing.
Any other questions for Liz? Yes, John.
I have a question in regards to first off, the city of Ithaca, I noticed that they're on the open DOH enforcement actions, and I received an email from constituents in regards to their concern that some of the waste and garbage that was at, I guess, Jungle One is moving to a different area. And I wanted to see if there are conversations about that.
So I met with the city and we went out to the site where the enforcement action was targeting. And then kind of did a brief survey of the other areas, which did bring things to my attention. And so I've started discussions internally. We've also received some other complaints. Related to the general issue, right?
Okay. Yeah, I think there were some concerns about.
Different locations,
Okay.
not just, so
Uh-huh.
anyway, we are working with the city and
Okay.
trying to look into some things. It'll take a while.
Okay,
There's no
I know.
easy answer.
Okay. Yeah.
But yeah, it is on radar again, being actively looked at. Else for this? Right. We're gonna go ahead and move forward with the enforcement actions, but you need to give me 1 second, because I gotta get back online. I messed up, or unless I seconded it. They're in the electronic. They're not in this one. It's okay. No worries, we're covered. But I remember them, it's okay, I don't remember the order of what is what, so I don't want to miss them. If you, that's okay, I got it, this is here. So our first enforcement action, just so for other board members, okay, so the first enforcement action is related to the Dos Amigos restaurant. And just as a reminder, this is the to pay a penalty for $200 for their violations. I think this was the first time in front of the board for them. And this was a temperature violation. And Liz, I don't know if this was. Is that general summer? It's hot holding, yeah, sorry. Issues at this location, that this is their college town.
Okay. Does anyone need any more background than that? Do you remember? Okay, so. Wait, before we go to discussion though, can we put it under a motion? Okay, so we have a motion to move forward as written, a first from Shauna, a second from Ravinder. Okay, Shauna, discussion?
Yeah, I just had a question in regards to making sure that they understand the violation. See if there are any language barriers that might be of concern.
I
I haven't specifically asked about that. Nothing has been mentioned, and I think it's kind of the same people that we're working with across their multiple restaurants, and that hasn't been the issue.
Okay.
So I don't, so he's the owner, this is a student of mine, so I don't know what that says about me as a teacher. But I don't know if I should, am I still allowed to like vote and all that if I know this person?
Why don't you recuse yourself for the purpose of the vote, just for, you've got quorum otherwise, so.
Second move, if we have to.
Okay, so can we change the move to second for Dr. DeLima from Ravender? Okay, any other discussion on this? Okay, all in favor, as written? No opposed, and we have one abstention. Ravender. Okay, so next one is, for Caribbean Patty World. This one is this is also a temperature violation. Yes, this was a $400 violation. It was for hazardous foods below 45 degrees during refrigeration. There was also a hot holding violation, etc. So if we could have a motion to approve this written.
And this is the first one too, right?
First from Melissa, what?
This is a first violation too?
Yes, I don't think any of these are part of.
Yeah, this is the first one too. It's just this one's, I'm thinking that it's more because there's more violations. The fee is higher because there's more violations. So we have a first from Melissa, second from our vendor. Okay, additional discussion on this?
Just point out, this is a temporary food service, not rest, the other ones were restaurants. Different code.
Any additional questions on this? Okay, all in favor is written. That's unanimous. All right, third one is for Tamarind. I gotta scroll down to it. Okay, this one is a $400 violation. This one is related to, Liz, can you just summarize this one? This was an application issue?
It's operating without a permit.
Oh, right, without the permit, okay. Okay,
That we're doing it time.
okay, so it's an operating without a permit, so approval as written. I have a first from Ed. I'm gonna have someone else, Samara. Want everyone, spread the joy, right? Okay, any additional discussion on this one? So it's a $400 penalty, requirement to submit the completed renewal application before the expiration of the previous permit, et cetera. Any other questions on this, comments? All right, all in favor is written. Unanimous. Okay, so then the administrative action, does that go under a vote too?
Yes.
Okay, so we have an administrative action as part of the packet. This was the request to waive fees for organizations functioning under the DSS as a co-blue shelter. That was part of the packet. So let's go ahead and put this, start with putting this under a motion to approve as written. I got a first from Shauna, a second from Samara. And Liz, can you just talk a little bit about this?
Yes, when DSS, Department of Services, was setting up both the family shelter at Econo Lodge and then the new shelter at Key Bank, they realized that some churches had been providing food and wanted to do that, and they actually need a permit for that. So we worked with DSS, they are getting the permit, and then all of the organizations will be operating under their permit, take training from us and stuff like that. So that's this, a couple of churches might have their own independent permit, but if they don't, then they'll operate under the DSS permit to provide food at both level.
Request here is to wait.
And to waive the fee.
Because it would be the county paying the county. Actually.
Well, other times we. Special circumstances.
So I've actually seen some rumblings about this and was wondering, I think one of the mentions, one of the emails I received said that they have to use a commercial kitchen. Is that right? Okay. And then the other question that I received is if they want to donate prepared food, is there any way for us to do like one of the blue cabinets in front of the shelter? Where people can drop.
If it's not temperature control, prepackaged food and stuff like that, we don't regulate that. This is food that's being prepared and served where it can make people ill if it's not done correctly.
Sure.
Okay, and so can I just paraphrase what you said so I make sure I understand, which is DSS is the responsible entity here. And then underneath them or working alongside them are the churches who would be providing the food. And so we're just waiving, DSS is the permit holder, we're waiving the fee for that. But you're still working with the churches to ensure that the food that they're providing is being prepared properly, that we're not making people sick.
They have to do it in a commercial kitchen, and we have, we've issued the permit already to Department of Social Services for this. Anybody who is serving the food has to take, we have a little online quiz that people who do temporary food service have to take. So all of the workers have to take that, so they get a basic education in food safety, and somebody has to be there overseeing the service of the food to make sure that nothing happens during that time period. So that some cases that will be one of the organizations that's bringing the food. Some of them don't want to stay, in which case DSS will have a trained person oversee that.
So it's not excusing them from safe food preparation. It's just that it's only waiving the fee.
No, they made multiple changes to meet the requirements.
Any other questions from board members?
One addition, there is limited commercial kitchens that are available. Some of the churches may meet that requirement, but not have a permit. So this is also saying if one of those charitable religious organizations wants to get their own food service permit, that we would waive the fee as long as it's for like this type of function. Some of the churches like rent out their kitchens and stuff like that, in which case we charge a fee. But if they're doing it just to help with this Code Blue shelter and similar things, we would waive the fee under this, what you're approving today.
Questions about that? Ready to vote? All in favor? And that's unanimous. Okay. So let's switch to the two items and let's just be mindful of time. So the first, so Shauna, I'll give you the floor about this piece of paper that's in front of us. So I don't know, maybe first if it would be helpful for Liz. Liz, can you provide the background on the CAVA?
So New York State Department of Health issued a letter that said that if a restaurant serves kava tea, kava in any form, actually, it is adulterated and must be embargoed. That affects the Sacred Root Kava Lounge because their main business was kava. So we informed them of this earlier this year. They asked us to, they provided some information, asked us to have it reviewed by New York State Department of Health, who said their initial ruling stands. We also left, but our medical provider, director, sorry, I'm getting those words. So, he also reviewed it and said that, in accordance with DOH, this is, we would need to not allow them to serve kava. So during this, we extended their current permit to give time. It was supposed to expire, I think, November 1, October 1, one of those dates. I think October 1. We extended it to the end of November. And then when we got the final rulings and said, okay, we need to, we can't renew their permit as it stands, we gave them extended it again through the end of December to give them time to process whatever they were going to do. In response to that, they have gotten back to us that they are modifying, they're taking kava off their menu and they're gonna be serving some type of teas, some types of drinks, and desserts is current plan. They're working with us on a menu. And so they intend to stay open is what they have relayed to us, and we are working with them on that now without serving kava.
And the most recent email this morning asking for the DOH.
Yes, the owner is asking us for what DOH, for the DOH response, but it was simply that their initial ruling stands. There wasn't any more explanation provided other than what was in DOH's initial, which we'd already given to Kava or to Sacred.
So Shauna, was there something in particular you wanted to?
Nothing much other than the fact that I think there are two states that have deemed kava a food item by the FDA, Hawaii and Virginia. And this is a business that is owned by two local individuals here in Ithaca. It's been open for 10 years. It's sad to see something like this happen to a longtime family here. I'm glad to hear that we're working with them to kind of recreate their business. I think I would ask that if we could see if there's any type of exception or exemption or local law or something that maybe we can do to protect this business. I personally have not heard of the harms of kava. I'd be more concerned about the junk that they're selling on the comments.
Being sold on the comments. So we did a review of the studies that DOH based their determination on, and there is evidence in those studies that there is potential negative impacts to your liver from kava usage. And so the way we were originally looking at it is the rule says you can't have an adulterant. Right? So that's the hard and fast rule. DOH made a determination that kava is an adulterant. So we were looking at, is there a way for us to disagree or perhaps do something differently to address it as an adulterant? Quite honestly, the studies really didn't give us that opportunity because it would be very difficult for us to, one, go against the studies and the DOH determinant, and then the risk that's associated with those types of things. We did have some initial conversations about local law and, what that might look like, but then it comes into, well, is there an age level that it's appropriate that we allow people to do it? And then how would we enforce that? And who would enforce that? And, we already struggle enforcing age limits on other things that are already out there. So there really wasn't a realistic way for us to kind of get around that. And quite honestly, there would be some significant liability related to the information that we have, and as well as going against the DOH determination. So that all kind of is part of the consideration.
One other comment though, that we can make laws that are more restrictive than the state law. We cannot make laws that are less restrictive.
Okay.
So it would be hard to do that.
Does this extension give them enough time to sort of rebrand themselves so they don't have to close their business?
I mean, we're working with them on that. They had submitted their original permit expired, I think it was October 1. And so they already had submitted that permit application. So we have that to process. We'll work with them on whatever needs to be done. They'll have to stop serving kava at the end of December. But
They can stay open and serve tea?
yeah, they can, yes, they can serve
Or
tea and
kombucha.
whatever their kitchen will accommodate.
Any other questions on this one? Thank you. Okay, so last thing is the nominating committee. And since we do need to talk about particular people, I'm looking for a motion from the floor to go into executive session. I have a first from Ravinder and a second from Ed.
Okay, so just for those that might be watching on YouTube in the future, we are gonna stop the YouTube recording. We will not be coming back to YouTube, but any action taken will be happening in public session. And that will be reflected in the minutes of this meeting if you're interested when those are posted. So check there for any action. And with that, give me 1 second and I will.
But we stay for executive session.
Or do you-
Can. I don't think there's.
Christina, I actually have like 4 people waiting for me in the
Okay.
office, so